Good evening, my dear professors and dear colleagues. It's my honor to present my case today. My name is Mai Morsi, assistant lecturer at Alexandria University. My case is a 22-year-old male patient from Kafr Sheikh. He's single and unemployed. He's non-smoker with no other special habits. He was complaining of fever, oral ulcers, and left hypochondrial pain weeks before admission. His condition started since 2009 with polyarthralgia. Then, 3 years later, he developed photosensitivity, malar rash, oral ulcers, and pancytopenia. He had anormocytic normochromic anemia. His hemoglobin was 10 gram per deciliter, thrombocytopenia. His platelets was 89, and leukopenia platelet white count was 2.7. CBC film at that time showed no abnormal cells. At that time, he was diagnosed as SLE by fulfilling SLAC criteria. He had positive antinuclear and SMAS antibody. Despite he had negative anti-double strand. Anti-RNP was positive. At that time, he was maintained on steroid hydroxychloroquine 200 milligram and azathioprine 50 milligram twice daily with a good hematological response. His hemoglobin increased to 10.5 gram per deciliter and white count increased from 3 to 4 and platelets 142 with improvement of his musculoskeletal manifestation. Then he developed discoid lupus on nose and behind his left ear. 3 years later, August 2015, he was hospitalized one more time with oral ulcers, leukopenia, with profound neutropenia. White count was 1.2 and with absolute neutrophilic count of 0.5. Thrombocytopenia platelet was 29. Ultrasound of the abdomen revealed at that time periportal hepatic fibrosis and mild splenomegaly. He was started on high-dose corticosteroid and MMF 1 gram. Hydroxychloroquine increased to 400 milligram per day. His CPC parameters rapidly improved within 4 days. His white count improved to 3.2 and platelets to 140. On early October 2015, he presented again with fever that increased at night, recurrent oral ulcers, left hypochondrial abdominal pain, and episodes of stitching chest pain 1 week before admission. He was readmitted to the hospital. By reviewing his past medical history, only bilharziasis, his family history was negative for any immunological or hematological diseases with no history of previous operation and no known allergies and no history of blood transfusion. On examination at that time, the patient was fully conscious and cooperative. He was vitally stable except for his temperature was 38.5. Head and neck showed pallor, lower lip ulcers, discoid rash on the nose, and tinea on the neck. Chest showed bilateral equal air entry with no adventitious sounds. S1, S2 were heard normally. Abdomen was lax, not non-tender, with only hepatosplenomegaly. Extremities showed no lower limb edema or arthritis. Peripheral pulsation felt. No palpable lymphadenopathy. On admission, his investigation was hemoglobin was 9.9 gram per deciliter, platelet was 88, white count 1.04, neutrophils was 200. By reviewing his investigation, uh, only the significant only ALT is slightly elevated was 41. His albumin was 3 gram per deciliter. Creatinine was 0.6. Complete urine analysis showed 1 plus protein with no cast or sign. C3 was mildly consumed, 85. His electrolyte were normal. LDH slightly elevated, 450. ESR markedly elevated, 120. CRP markedly elevated 91, and his double strand is persistently negative. To sum up, we have a SLE patient diagnosed initially with hematological manifestation, leukopenia, thrombocytopenia, mucocutaneous manifestation, and arthritis, with recurrent hospital admission with hematological activity. Now he's presented with fever, hepatosplenomegaly, pancytopenia with profound leukopenia. This case was presented at 2015. If these cases presented nowadays, we first should exclude infection, and he will be suspicious for COVID first. Our differential diagnosis was SLE activity. Would we shift to cyclosporin or viral infection or hematological malignancy? A blood culture was done and empirical antibiotics started. Virology was negative. Epstein-Barr virus IgM was negative, although his hematological parameters again improved very rapidly after giving high dose of corticosteroid. At that time, CBC film was repeated for exclusion any hematological malignancy because the patient has persistent hematological activity with hepatosplenomegaly and fever that increased at night. His CBC film at that time showed hemoglobin 9.3 gram, platelets 84, white count 1.3 with 8% plus cells. CT chest and abdomen showed hepatomegaly 20 centimeter at the midclavicular line, splenomegaly 19 centimeter with no focal lesions and no masses, with no lymphadenopathy. At that time, bone marrow aspiration was done and showed aggressive natural killer cell leukemia with plus cell 86%. Immunophenotyping was done and showed surface CD3 negative, which is goes with T lymphocytes. CD16 and CD56 were positive, and T cell receptors negative. This figure is diagnostic for natural killer cell leukemia. The patient received chemotherapy cycles with cyclophosphamide, adriamycin, dexamethasone, vincristine, L-asparginase. But unfortunately, 2 months later, the patient died from fungal infection. Um, Although the incidence of leukemia in the patient with SLE is increased up to threefold in comparison to the general population, the relationship between the two diseases is still imprecise. Natural killer cell leukemia is rather an aggressive, uncommon type of leukemia that's extremely rarely to be associated with SLE. This co-occurrence was only reported once in the literature where a patient had SLE, tuberous sclerosis, and natural killer cell leukemia. These cases, together with other previously reported cases of leukemia in SLE patients, point to a potential pathogenesis by which SLE can increase the risk of leukemia, especially in the patient with hematological activity. This is the case report of coexistence of systemic lupus, tuberous sclerosis, and aggressive natural killer cell leukemia. It was published 2016 in Netherlands. Is it coincidence or correlation? In addition, a notable relation between prolonged exposure to large cumulative doses of azathioprine and hematological malignancy, especially acute myeloid leukemia, was reported in the literature implicating it as a leukomogenic agent. So, my take-home message, the sequence of the events in this case points to the importance of keeping a high index of suspicion for the possibility of a hematological malignancy when a patient with SLE is having a refractory hematological activity accompanying with hepatosplenomegaly, pyrexia, and weight loss. The initial response to steroid therapy may be misleading as it decreases the lymphocytic burden of the tumor and by inhibiting the natural killer cell activity and proliferation. Thank you.